So we are saying that for the clinical presentation, always think of what? Crab. So the crab, we are referring to what? Calcinosis, renal failure. We are referring to anemia. Then again, bone or back pain. You should know that. You should know again that bone or back pain is the most common, as we said, most common presentation. Is the most common presentation. Please, are we clear on that? Is that clear? Now let's talk about the clinical features. So always remember, please, they will tell you that okay, a renal function test done revealed elevated levels of creatinine, telling you that creatinine clearance is what? Poor. That is an indication that the kidney is not functioning as it's supposed to. Is that clear? Now let's talk about the clinical features. Clinical features. For the clinical features, let's take the first one. Hypercalcemia. Hypercalcemia. So hypercalcemia, how are they going to be? What are they going to be presenting with? They will come with what? What will they come with? They will come with nausea, vomiting, increased thirst, constipation, and what? Altered mental status. Okay? Nausea, vomiting, constipation. They will come with increased thirst and altered mental status. Altered mental status. Another thing that they can also come with is what? Anemia. They will have neutropenia and also thrombocytopenia. And each of them will be given respective stuff. If there's neutropenia, what will happen? You have infections. If there's thrombocytopenia, what will happen? If there's anemia, what will happen? They'll be what? Dizzy, right? Are we following? Signs of anemia. Symptoms and signs of what? Anemia. That is true. Okay? That is true. That is very true. Also, there will be what? What else can be present? Coolly. Clinical features. Yes, we said yes. There will be. We made mention of what? They will have bone pain or back pain. Okay, bone pain or back pain. Bone pain or back pain. Okay. Then again, they can also come with what? Recurrent infections. Recurrent infections. Recurrent infections. So do you know how we are going? We are just using the crab, calcinosis. Look at what we are saying. Anemia, renal failure, and all that. Anemia, we are going that way. Bone pain, we said the bone pain. Recurrent infection. Recurrent infection, why would there be recurrent infection? There are three reasons why. One, you should know that there is neutropenia. So recurrent infections, the first one is due to neutropenia. Neutropenia, okay? Neutropenia. Remember the second definition that we gave? We said that it's a plasma cell malignancy in which monoclonal plasma cells proliferate abnormally in the bone marrow, resulting in an overabundance of monoclonal paraproteins, the destruction of the bone, and the displacement of other hemopoietic cell lines. So if I say other hemopoietic cell lines, if the neutrophils are suppressed, will you be surprised? If the erythrocytes are suppressed, will you be wondering? The thrombocytes, if they are suppressed, will you be wondering? No, because there has been a displacement of what? These hematopoietic cells or hemopoietic cells. Are we getting that? Are we following? So yes, it is due to what? Neutropenia. Another one is immunoparesis. What is immunoparesis? Do you know what this means? If we take multiple myeloma, what's the dominant immunoglobulin? G, right? And the moment the G is in abundance, it suppresses the others from being produced. Are we getting that? So you only have G and the others are not there. And the others also have other functions. So at the end of the day, you have paralyzed the others which are not being produced. And if there's immunoparesis, there is high risk of what? Infection. What's the most abundant immunoglobulin in circulation? Only one attempt. If you know, you can raise your hand. Yes. IgG, that's correct. Immunoglobulin G. And we always say that remember to play the game of football. And if you have lost, then you say that you have been gamed. So G, okay. So decreasing. So it means that G is the abundant, followed by A, followed by M, followed by E, followed by D. Is that clear? So immunoparesis, and also if that patient is on what? Chemotherapy. Because you know that chemotherapy can also suppress immunity. True or false? True. Please, are we getting that? Thank you very much. Then the next one is what? The renal insufficiency. The next feature is renal insufficiency. What will account for the renal insufficiency? So let's talk about that, okay? Before we talk about that, you should know, when we're talking about the paraproteins, we said that paraproteins can be discovered on serum electrophoresis and also on urine electrophoresis, right? Okay. The one that you discover on serum electrophoresis, we call it the monoclonal paraprotein bands or the monoclonal bands or monoclonal paraproteins. But the ones that are discovered in the urine, we call them what? The Burns-Jones. Is that clear? Burns-Jones proteins. Okay? Burns-Jones. So if you hear, in which condition would you have Burns-Jones? Name two conditions in which you can, these can be found. Burns-Jones proteins. Two conditions. Two conditions. Yes, anyone. Multiple myeloma and what? And what? Hey, we are trying to be political. Yes. Multiple myeloma and... No, if you say paraprotein, then why are we saying multiple myeloma again? So multiple myeloma and what? Monoclonal gammopathy of undetermined significance. You're wondering, eh? So those two conditions, yes. So what are Burns-Jones proteins? Please, we are putting on the side, okay? We will come back to we will come and explain the renal insufficiency. What are Burns-Jones proteins? Yes, anyone? So please take note that Burns-Jones proteins, they are free immunoglobulin G light chains. They are free immunoglobulin G light chains. Free immunoglobulin G light chains of the kappa and lambda. The kappa and lambda. Mainly, we will say that mainly, please let's take note, mainly it is as a result of mainly it's as a result of the precipitation. Mainly it's as a result of what? The precipitation of the light chains by the thumbs TAM host 4 proteins. TAM host 4. Precipitation of the light chains by precipitation of the light chains by the TAM host 4 proteins in the distal loop of Henle. In the distal loop of Henle. Distal loop of Henle. In the distal loop of Henle. Okay? Yes. It's double M. I'm right? It's double M. TAM host 4. TAM host 4. And you should know. Okay, so when these light chains are precipitated by the TAM host 4 proteins in the proximal loop, in the distal loop of Henle, it causes the major injury to the kidneys. Then the question is, what is a TAM host 4 protein? Yes.
TAM host 4 proteins, these are proteins which attack infection. They attack antigens like infections and form this kind of complex so that they are seeped out. But in multiple myeloma like this, these proteins go and attach to the free light chains, which then causes this complex which is deposited in the proximal or distal part, which causes the injury which you spoke about, which is deposited in the...
Yes, you have a point. You have a point. That is true. So the TAM host 4 proteins, they are they are natural proteins that are secreted by the kidney. Okay. The reason why they are secreted is in such a way that whenever the TAM host 4 proteins, when they bind to bacteria, they tend to inactivate them, decreasing the incidence of urinary tract infections. Because of that, the TAM host 4 proteins are also known as Neuromodulin. Neuromodulin. Okay? Neuromodulin. Okay? So the TAM host 4 proteins, they bind to they bind to bacteria, inactivating them. Okay? They bind to bacteria, inactivating them. Okay? Decreasing the incidence of urinary tract infections. Okay? That's what we call the TAM host 4 proteins. TAM host 4 proteins. Okay? TAM host 4. TAM host 4 proteins. TAM host 4 proteins. So in this case, yes, the precipitation of the light chains by the TAM host 4 proteins in the distal loop of Henle, yes, is what will account for the renal insufficiency. And again, bear in mind that it is not only as a result of that. Even the deposition of the monoclonal immunoglobulins in the kidney can cause the damage. And if you have a multiple myeloma associated with a primary amyloidosis or associated with amyloidosis, which is primary, then you expect the AL amyloid to be deposited where? In the kidney, causing what? Kidney injury. Is that clear? Is that clear to you? Please, are we clear? No. I should do what? I should repeat. Okay. So, the TAM host 4? The TAM host 4 proteins. Okay, I'm saying that the TAM host 4 proteins, they bind to bacteria along the urinary tract, incapacitating them. They inactivate them, meaning that that bacteria will not be able to cause any inflammation along the urinary tract. So if you have efficient secretion of the TAM host 4 proteins, it means that relatively you are likely to have a low incidence of UTI as compared to somebody who is not having sufficient secretion of the TAM host 4 proteins. And we are saying that in multiple myeloma, these TAM host 4 proteins become what? Affiliated. They become attracted. Okay? They have an affinity for the light chain, such that when they will bind to them and precipitate, they will form a complex which will be deposited in the distal loop of Henle, causing what? Inflammatory changes to the cells, toxic changes to the cells in the distal loop of Henle. That's the damage that we are talking about. And I'm saying that aside that, the deposition of the monoclonal paraproteins, in this case we are looking at the immunoglobulin G, in the kidney, the nephrons, can also cause what? Damage. And I'm also saying that If you have a multiple myeloma associated with primary amyloidosis, as we give as a differential of what? Paraproteinemia, it can also lead to the deposition of AL amyloid in the kidney, precipitating a kidney injury. Do you get that? Okay, that is fine. Now, yes.
So with this, with the renal insufficiency, would this explanation also explain for the infection, increased infection? Since now this
And the Neuromodulin, it will not be a major reason why. The major reason is what we gave: neutropenia, the immunoparesis, immunosuppression. Those should suffice. Because urinary tract infection, yes, it may happen, it may not, but the major factors are the things that we mentioned. Okay. All right. Let's move ahead. Okay. Let's move on. Now, let's look at the investigations that we can do, which will help diagnose multiple myeloma. Investigations. So the investigations, we can do what? A full blood count, right? The full blood count, what are we going to be looking at? There will be what? Anemia, true or false? Which kind of anemia will be here? It will be more of anemia of chronic disease, and they should take the picture of what? A normocytic, normochromic anemia. Exactly. Normocytic, normochromic anemia. It will be NN. Normocytic, normochromic. Normocytic, normochromic. Normocytic, normochromic. What will happen to the white blood cell, the neutrophils? There will be what? Neutropenia. And also, we can think of what? Thrombocytopenia. Will you want to do ESR? ESR stands for erythrocyte sedimentation rate, and the units will come in the sense of what? Millimeter fall per hour. Okay? Millimeter fall per hour. And again, ESR will be what? Persistently elevated. Persistently elevated. Please, are we getting that? Then we can also do serum electrophoresis. Oh, you find they will have what? Monoclonal what? Bands. Or monoclonal what? Paraproteins. Okay? Monoclonal bands or monoclonal paraproteins. Exactly. So serum, see, this is how it's going to look. We are going to have this assay. So you have immunoglobulin. Let's take this as immunoglobulin A, immunoglobulin G, immunoglobulin M, immunoglobulin D, then immunoglobulin E. So now, if this is multiple myeloma, you take the serum and you do an electrophoresis, there's going to be a blue or green light depicting the band. So you will see that here there will be a control. They have a control which will have that band. Then you will see that G will have this band, the rest will not have. Telling you that immunoglobulin G is what is present there. So that becomes a monoclonal paraprotein in multiple myeloma. Is it? Is it a gold standard? For multiple myeloma? Well, for multiple myeloma, that alone will not suffice. Are you getting that? But it's highly sensitive. Okay, it's highly sensitive. Highly sensitive. Is that? Yeah, bone marrow biopsy would be a better option to go for. Okay. So yes, serum electrophoresis, you have monoclonal paraproteins. Urine electrophoresis, what will you find? What will you have? Excellent. You have Benz Jones. Do you have any Jones here? If you don't have any Jones from today onwards, Clifford, you are Jones. So that you always remember that anytime you urinate, and we should do An electrophoresis, you would think for multiple myeloma, you are looking out for what? Benzones, proteins. They are also paraproteins anyway. And we know that benzones proteins, they are what? Free immunoglobulin G, light chains of kappa and what? Lambda type, filtered by the kidney. Is that clear? You are doing well. That's good. Now the next one, we can do what? Bone marrow biopsy. And what will be your finding? Aziz? What will be your finding? Quickly. There will be what? More than 10% of what? Plasma cells. Can't we do serum calcium? Can't we do serum calcium? It will be elevated. Can't you do BE and creatinine? Can't you do BE and creatinine? Why would you do BE and creatinine? Yes, there will be what? Renal failure, which will be depicted in the case of what? An elevated creatinine, okay? Please, are we following? We can also check for the serum beta 2 microglobulin, which is more flexible in what? Prognosis. So it's a prognostic what? Factor. Is that clear? Is that clear? Are we clear on that? Yes. Okay. Which other investigation can we do? We can do what we call skeletal survey. True or false? Skeletal what? Survey. What is a skeletal survey in this case? We will say X-ray of the what? Of the skull, not the bone. X-ray of the skull, the spine, chest, and what? Pelvis. That is correct. Okay. And what will be your finding? Aziz, what will be your finding? There will be what? There will be what? Osteolytic or lytic punched out lesions. Lytic punch out lesions. And if you have this on the skull, then we'll describe that skull as what? A pepper pot what? Skull. A pepper pot skull. Okay? Do you understand? Please, let's get a picture of that. Dr. Clifford? Let's get a picture of that. Dr. Jones Clifford. Let's get a picture of that. Okay? So it looks like a coin. You see the way the coin is? You will see a lesion. Like if this is, I don't know whose head is this, but so there will be, okay, like a coin. The whole place will become very white, hypodent. It will be white, okay? Let me see. Yes, that's it. You can see. Okay, so the one you showed to me not long ago, the one that has it, the one that looked like, you showed me some not long ago. This one, yeah. So you have pepper pot skull, okay? Please, are we clear on that? We can also do liver function test. Why are we doing liver function test? Because of the albumin. The albumin can also serve as what? A prognostic factor. Is that clear? Is that clear? Now, yes. Please, why? Don't worry, when we get there, we would open it up and it will become visual. Okay? Become visible. Yes.
Can you have osteoporosis?
Yes, we'll get there. We'll talk about that. Yes. We'll talk about that. Talk about that. Skeletal survey. Okay. Now, there's something, she asked a question, and it's something very important that we should add to the clinical features. Okay, so let's add that to the clinical features. That will be what? The bone lesions. The bone lesions. Let's add that. Okay, bone lesions. Let's add that to the clinical features because I think we only spoke about the hypercalcemia. We didn't talk about the bone lesions. Okay, the bone lesions. The bone lesions there can, so the feature in that would be, the first one you can think of pathological fractures. The second one you can think of osteoporosis. And the third one, vertebral collapse as part of the clinical features. As part of the clinical features, bone lesions. And under the bone lesions, we are looking at what? Pathological fractures, osteoporosis, and what? Vertebral collapse. Okay. So those are some of the things that you can use the skeletal survey tool to also watch out for. Bone disease, vertebral collapse. All right, let's move ahead. Now let's move on. Now, please, I hope you are following and you are enjoying the session as well. That's what the candidate always says. Until you ask questions. When you ask questions, then we'll be having, yes. Look at the down there. I told you it looks like as if there's a coin. It looks as if there's a coin. Okay. All right. Now,